Hello everyone, this is Dr. Chandrasekhar, and in this video we are going to discuss about an important surgical emergency, that is bowel perforation. To begin with, what is bowel perforation? So bowel perforation is nothing but loss of continuity of the bowel wall. Okay, loss of continuity of the bowel wall is called bowel perforation, and it may result from variety of disease processes, and it is a devastating complication. Okay, so what are all the important disease processes that can lead to bowel perforation? So that is the pathophysiology. We will see the first most important cause is the gastric and duodenal ulceration. Peptic ulcer disease can erode the wall of the ulcer, erode the serosal layer, and can cause perforation. And next important cause is the infections. In infections, like we have seen, perforated appendix can lead to perforation, and diverticulitis can rupture, and they may lead to perforation. And ischemia is an important cause, like in IBD, perforation can be there, and in advanced stages of cancer the cancers can erode into bowel wall and cause perforation. And third important cause is the blunt and penetrating trauma. As we have seen, knife injuries and injuries with other sharp objects can cause bowel perforation. And next, fourth important cause is ingestion of corrosive materials like acids and alkalis can cause perforation. Okay, and last but not the least, iatrogenic causes are an important cause of bowel perforation, like ARCP has been known to cause bowel perforation, colonoscopy and endoscopy during laparotomy, and in biopsy procedures in USG guided biopsy or CT guided biopsy. Bowel perforation is an expected complication if we inadvertently injure the bowel wall. Okay, moving on to clinical picture. So how will the patient present to a emergency department? First thing is the patient will have the severe abdominal pain, and the symptoms depend upon the location of the perforation. If it is a upper intestinal perforation, the pain will be severe and generalized. If it is a lower intestinal perforation, then the pain will be gradual and localized pain. And additionally, patient will have anorexia, nausea, and vomiting. On examination, the rigid abdomen can be seen, and there will be generalized tenderness. Guarding will be there, and vowel sounds will be quite or absent. So this is the clinical picture with which a patient will present. And this is a small diagram which shows whatever I have discussed till now, like what are the causes and signs and symptoms in a bowel perforation. And this is a diagram taken from the Osmosis website. And moving on to what is the role of imaging? Imaging from a radiological perspective. So radiologist should answer three questions for a referring surgeon. First thing is whether there is a pneumoperitoneum. So we have to confirm whether there is a free intraperitoneal gas or not. Second thing is we have to determine the underlying cause. And the third thing is we have to, if possible, we have to find the site of perforation. So these three questions we have to answer: whether there is a pneumoperitoneum or not, whether what is the underlying cause, and what is when we have to identify the site of perforation, if possible, on radiologically. Moving on to what are the important in radiological investigations. Most important is the erect plane chest radiograph, and it's a very sensitive for even for a small volumes of gas, like we can detect even 1 ml of free gas if properly performed. And second important investigation is the supine abdominal radiograph, and it may show signs of free gas if the amount of pneumoperitoneum is more. And ultrasound has an additional role in detecting pneumoperitoneum. And for most important, this is the CT with IV contrast, the gold standard investigation, because it can identify free gas and fluid within the peritoneal cavity, and it can help us to identify what is the cause and what is the site of perforation. So moving on to, in plain radiograph like erect chest X-ray, it is sensitive even for small amounts, and we can see a crescent under the diaphragm because of the air under the diaphragm. And the most important precaution we have to take while performing it is we should position the patient erect for at least 10 minutes. Okay. If we directly take the erect chest radiograph, then we may not be able to detect the air under the diaphragm. If you give at least 10 minutes, then the air will slowly settle in the subdiaphragmatic cells and it can be identified. And abdominal radiograph can be has might have been performed for other reasons like to identify bowel obstruction. So in that we can detect free air. So some of the signs of pneumoperitoneum, there are several signs of pneumoperitoneum, and most important is the regular sign. So we'll see. This is the erect chest radiograph. As you can see the air under the diaphragm on both the sides. And the chest radiograph, basically the air in the lungs will get contrasted with the air in the in the peritoneal cavity by outlining the diaphragm. Moving on to this is an important sign, regular sign, that is presence of air on either side of the bowel wall. As you can see, this green arrows are the air within the bowel wall, and white arrows are the air outlining the bowel from outside. So air from inside and air from outside will outline the bowel wall. It can reach to bowel. It will help us to detect the pneumoperitoneum. Okay. And then this is the football sign, second image. So we will discuss about, so there are some similar signs compared to regular sign, like what is regular sign, what is regular notch sign, and Hoffman regular sign. These all three are different signs. Coming on to football sign. Football sign is seen in abdominal radiographs, and it is useful in the infants and neonates and not in adults. In infants and neonates, as you can see in NICU setup and all, what happens is actually children cannot be, it is very difficult to take correct radiographs. So in such children, a large oval radiolucency in the shape of an American football can be seen. This is the whole thing. As you can see in this image, there is a large oval radiolucency because of the free intraperitoneal gas, and within that, as you can see, there is a thin line here over here, thin radio, that is nothing but the falciform ligament which has been made prominent by the free gas within the abdomen. So this blunted ends are defined by diaphragm pelvic floor. Diaphragm will make the upper end of a football, and this pelvic floor will make the lower end of the football. And here falciform ligament will make the upper suture, and medial umbilical ligaments, it is not seen properly in this radiograph, but that is the like that is compared to a sutures in a football, like American football. So this is like a football, and this is falciform ligament, and this is median and medial umbilical ligaments. Okay. So and the same thing, that falciform ligament being made prominent because of the air outlining it is also called falciform ligament sign. That is also an important sign to detect pneumoperitoneum. Moving on, so I just said there are some similarly named signs. So that is Hoffman regular sign. This is entirely different sign which is seen, which is used to detect the amount of pneumoperitoneum. Yeah, and this is used to detect the left ventricular enlargement. As you can see in the first diagram, this is the where my cursor is going on is the diaphragm, and this is the IVC. The point where IVC and diaphragm intersect each other. This From this point we have to go 2 centimeter upwards. So we have to go 2 centimeter upwards, and from that point, for the distance for which the left ventricle is extending posteriorly is measured. As you can see, the A distance is measured. So this distance, if it is more than 1.8 centimeter, it is indicative of left ventricular enlargement. So this is the Hoffman regular sign. Okay. Then moving on to, there is one more called regular notch sign. This regular notch sign is a it is seen in solitary pulmonary nodules. Okay. So here what happens is there is a notched indentation of the lateral wall of the mass. So as you can see, this is the mass and this is the notched indentation. There is a notch and there is a notched indentation. So this is because of the vessel entering that nodule, and this was initially thought of as a pathognomonic of malignancy, but now It is seen in many, even in benign conditions like bronchial adenoma. So it no longer holds true, but that is called regular snotch sign. And coming to, there's one more thing called regular triad. It is a triad of pneumobilia, small bowel obstruction, and ectopic calcified gallstone. Here you can see there is a air within the CBD, that is pneumobilia, and then bowel obstruction and ectopic calcified gallstone. So these are the signs on plain radiographs. And coming to ultrasound, ultrasound is not a primary modality for evaluating pneumoperitoneum, but free gas within the lining the peritoneal cavity can be appreciated on the ultrasound, and we can even ask the patient to move in a lateral decubitus positions and allow the gas to raise to that position, and we can examine. And we should have to differentiate it from where, that is within the bowel lumen. Okay. So next will come the most important part, that is CT. Abdominal CT with IV contrast is the gold standard investigation. It is very sensitive even for a tiny volumes of free gas within the abdomen. Triangles or bubbles of gas out of the bowel can be detected. Anti-dependent rising to the top of, that is behind the abdominal wall. Okay. So it is associated fluid within the peritoneal cavity. Fluid within the peritoneal cavity is helpful, but it is not specific for perforation. So what are the few in CT? What we can demonstrate is, first thing, extraluminal air and extraluminal contrast. If we have done the oral contrast study, then we can demonstrate extraluminal contrast. And in some cases, we can directly demonstrate the discontinuation of GI wall. So these are the three direct signs. And indirect signs are abscess or phlegmon related to the bowel. Bowel will be there, and surrounding with abscess or phlegmon can be seen. This is called sealed up perforation, which is this is also commonly seen. Okay. And then extraluminal enterolith or foreign body is also an indirect sign of bowel perforation. Then subtle pneumoperitoneum could be picked by some techniques. We have to use wide window setting, that is bone or lung algorithm. Uh, I will show that in the next slide in a diagram. And then we have to pay particular attention to the anterior peritoneal surfaces of the liver, mid abdomen, and peritoneal folds for subtle free air. So we'll see this diagram. As you can see, what exactly happens is, soft tissue window, even fat looks black, and air also looks relatively black. So here what happens is, so it is very difficult to differentiate fat from air in a soft tissue window. But when you put the things in bone window, so air will look black while the fat will look relatively grayish. So in that, okay, for example, is the same patient, same image. So it is very difficult to identify this foci of air here, and there is a foci of air here. There is no difference between this and this fat, so, but that is made evident in this bone window. So here also there is a subtle air foci. So this could be easily made out, and this air foci could be missed if you just see the soft tissue window. So always look for abdomen, screen abdomen in a bone or lung window to identify subtle air. Then finding the site and cause. So it is useful to find the cause of perforation. So that this is a very useful to plan the surgical management. As a dictum, where there is a more gas than fluid, then think of lower GI perforation. Where there is more fluid than gas, then think of upper GI perforation like duodenal ulcer. Okay, so more gas is seen in lower GI perforation, and more fluid is seen in upper GI perforation. Moving on to how to identify the site of perforation. Okay, these are the few techniques. First thing is, first tracking the pneumoperitoneum towards the region of a bowel. If gas is in the upper abdomen, then upper GI perforation is more likely. If the gas is found within the pelvis, then lower GI perforation is likely, that of the colon. Okay, if gas is extraperitoneal, then perforation site is likely to be retroperitoneal. Okay. And then localized peritoneal fat stranding, bowel wall thickening, abnormal bowel wall enhancement can be seen at the site of perforation. And sometimes you can directly see the bowel wall discontinuity. See, bowel wall discontinuity is seen directly demonstrate the perforation, but in absence of its clear evidence, these features like fat stranding, bowel wall thickening, abnormal enhancement will give a clue to what could be the possible site of perforation. Then, if we cannot identify, then we can go for oral contrast. Okay, so this can demonstrate leak, contrast leak. So we have to give a water soluble contrast. So that will help us to demonstrate leak of the contrast from the site of perforation. If bowel perforation occurs due to obstruction, the perforation usually occurs at the site of maximal bowel distension, and the perforation may be may not be seen at the exact site of obstruction. So, for example, this is the obstruction. So, the site where the bowel is getting maximally distended is the site where perforation is most likely, not at the transition zone of obstruction. And lastly, bowel perforation may not result in pneumoperitoneum in all the cases, as we have already seen in sealed up perforation and all around the bowel. We can see a collection or a phlegmon or abscess formation without pneumoperitoneum. Next, this is a brief table that will give a clue to the perforation site. So, for example, as you can see, in stomach or duodenal perforation, amount of free gas will be abundant, and it is mainly seen around liver and stomach and right anterior pararenal space. Okay. In small bowel perforation, amount of free gas will be less, and it is seen in mesenteric folds and around the liver. Okay. And in appendicular perforation, the free gas will be very small or it is absent and is seen around the appendix. In large bowel perforation, the amount of free gas is variable and is seen in the pelvis, mesenteric folds, and in the retroperitoneum. Okay. So this is like based on the amount of free gas and its location, we can get a clue what could be the site of perforation. Then we will discuss few examples, like few cases of esophageal perforation, gastroduodenal perforation, small bowel perforation, appendiceal perforation, and large bowel perforation, just to have an idea. Firstly, esophageal perforation, as you can see in this diagram, this is the trachea, this is the esophagus. You can see two lumens, and to ascertain oral contrast was done, and here oral contrast is seen in the upper lumen, while this free gas is seen lining the posterior wall of the esophagus. This is clearly seen in the sagittal image. Here contrast is there, and this is the free gas lining the posterior wall of the esophagus. Next, gastroduodenal perforation. Here, as you can see, this is the site of perforation. Okay, in this is the air, this is the lung window. Okay, here free gas is seen, and as you can see here, this is the pneumoperitoneum on both the sides, and they are lining a fold of ligament. This is nothing but falciform ligament. Okay, this is connecting anterior abdominal wall with the liver. So that's falciform ligament becomes well defined. Okay, and this is the Bowel loop. LL demonstrated is the Bowel loop. This is the free air, and this is the falciform ligament. This is the and here as you can demonstrate the site of perforation. Next, as you can see here, oral contrast was given, and there is a leak of contrast at the site of perforation, and this contrast is seen to be seen going in the subdiaphragmatic space, and it is also seen in the pelvis because of dilution of the contrast. It is seen in a lighter shade. Okay. Next, this is another example of post ERCP duodenal perforation. Okay. This is the site of perforation, and this is the free air. So this is iatrogenic perforation. Then there is a small bowel perforation. In axial sections, you can see there is a discontinuity, free air and fluid. So it is not evidently seen what is the site of perforation, but in sagittal image of the same patient. You can see there is a discontinuity, and there is a you can see there is air foci and collection outside the bowel wall. So this is a jejunal perforation. Okay, and then coming to like traumatic perforation. This is a traumatic small bowel perforation secondary to injury by a knife injury. So here this is the knife injury site, and this small bowel perforation has resulted in free air outside the bowel wall. And then appendiceal perforation, free air will be limited, but there will be formation of collection and inflammatory response in the surrounding region. Then this is a case of large bowel perforation. Here, this is a 75-year-old man with perforation of sigmoid colon. Okay, transverse CT image shows extraluminal fluid level adjacent to sigmoid colon with mural thickening and enhancement. So there is a mural thickening and enhancement, and there is a extraluminal air fluid level. As you can see, this is the air and this is the fluid collection. So this is a small large bowel perforation. And this is a case of rectal perforation. Here you can see this is the rectal wall, and there's a discontinuity here, and air is seen outside the rectal wall. And this air is tracking along the perirenal space on both the sides. So these are the different cases of perforation. And finally, treatment involves fluid resuscitation and IV antibiotics, and surgical intervention is often required. So, a surgical intervention is required to close the perforation, and bowel resection may be required. So, the bowel resection and anastomosis is done if the large segment of bowel is involved, and mortality increases longer the surgical treatment is delayed. Here comes the role of surgeons and radiologists in early identification and prompt surgical management of these cases, because the more the treatment gets delayed, more the mortality. So it's a life or death situation for the patient. So take home message is, it is very crucial to make a prompt and correct diagnosis of GI perforation. We have to confirm there is a pneumoperitoneum or not, and then we have to confirm the cause and site of perforation. Then if it is managed appropriately within the right time frame, then patient can be saved uh, easily. So here the role of radiologist in guiding surgeon for his surgical management is a very important thing. So with this, I will conclude this topic. Thanks a lot for listening. Take care.